Hi, I'm Dr. Howard Jack West, and I'm a medical oncologist with a particular focus on thoracic oncology. I'm an associate clinical professor in the medical oncology division at City of Hope, and I also lead a program called Access Hope that works on remote consult services there. And I'm based in the Los Angeles area. I'm happy to welcome all of you to this multidisciplinary tumor board on a series of provocative lung cancer cases.
Hi, I'm Michelle Ginsberg, and I'm a director of cardiothoracic imaging at Memorial Sloan Kettering Cancer Center. And I'm also vice chair for education in the Department of Radiology, also at Memorial Sloan Kettering. And I'm also a professor of radiology at Weill Cornell Medical College, which is across the street from Sloan Kettering in New York City.
Hi, everyone. I'm Suresh Ramalingam. I'm a professor of hematology and oncology at Emory University and the Winship Cancer Institute. Like Dr. West, my focus is also on thoracic oncology.
Hi, I'm Seth Force. I'm the Kamal A. Mansour Professor of Surgery and Chief of Thoracic Surgery at Emory University in Atlanta, Georgia.
Hi, everybody. My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis, and I am the chief of the Cardiothoracic Radiation Oncology Service and director of clinical trials.
58-year-old former smoker, T3N3 contralateral lymph node versus a primary on the left, known to have PD-L1 and a KRAS G12V positive mutation. Cough, dyspnea, and hemoptysis. Performance status is 1. This patient has a few miscellaneous past medical issues, has been treated for Hep C. Prior tobacco, no alcohol or drug use. Planning, chemoradiation, carbopaclitaxel. We'll go through imaging and then talk about carbopemetrexed. And we'll just go through imaging and see if we agree with that. And is there a role for surgery?
We see that there's a 6.3 centimeter left upper lobe mass, which extends to the pleural surface and is very FDG avid with an SUV of 18.4. Also, there's adenopathy, which we don't have on these images, but it is FDG avid, specifically in the right paratracheal. And I think even on the CT, you could see up in the upper right paratracheal region, there is a slightly enlarged lymph node. Additionally, there's subaortic lymph nodes, left hilar, and subcarinal lymph nodes, all with avidity up to 6.3 cm. So essentially, we have a left upper lobe mass with contralateral and ipsilateral lymphadenopathy, and based on PET, highly suspicious for metastatic disease to those nodes.
Okay. So we have this workup. Let us presume that this patient has documented N3 disease. I'm going to redo that. Dr. Force, can we clarify, are you inclined to say there is not a role for surgery here and that you would favor a chemoradiation-based approach, or would you leave that open? Well, what are your thoughts here?
Yeah, so I mean, I would never say never, but I don't think there's any data to suggest that surgery really has a role in patients with N3 disease in terms of improving their long-term survival over non-surgical therapy alone. So the only things I would add that, I think it was done here, but in all these cases, we obviously like to pathologically stage patients when possible, not just look at the PET scans, as we've said before. So you do want to make sure that they are pathologically staged as N3, not just something lit up. And I think surgery would be really reserved for if there are any complications or issues around the non-surgical therapy, or occasionally these patients get treated, they have a good response, and 8-9 months later, they get recurrence locally where the cancer was, but not in the lymph nodes. And we do go back occasionally and operate on those patients at that point to take the lobe out. But I would not do a neoadjuvant type treatment. I would treat them definitively with chemotherapy and radiation and reserve surgery as a later role if necessary.
Ram, do you think carbopemetrexed is a perfectly acceptable, good choice here for the systemic component?
Yes, I think it's a acceptable regimen. The non-inferiority trial that was done between pemetrexed-based regimen and cisplatin etoposide regimen showed that these two groups did very comparably, perhaps less toxicity with the pemetrexed-based regimen. So it's certainly a reasonable approach. The weekly carboplatin paclitaxel radiation approach is also appropriate in this situation. And whatever the particular group that is taking care of this patient is comfortable with would be appropriate between the two regimens.
Cliff, you also largely in agreement with the chemoradiation, presumably potentially followed by durvalumab consolidation for someone like this?
Yeah, I think the overall approach sounds solid. The one thing I will mention about that trial, though, the Proclaim trial, is that I think it's often touted as demonstrating, and it does, that there are less drug-related adverse events with the carbopem arm. Hidden in that paper, though, there's twice as much pneumonitis. So pemetrexed increases the risk of pneumonitis. Taxanes also do, but it seems like largely not to the degree of PEM. So when you have a patient with 3B disease, by definition, you're now crossing into the contralateral lung. And so your lung volume receiving radiation doses is going to be higher. So there may be a consideration for choosing a regimen that's less likely to contribute to that.
Okay. So I'll just summarize by saying that overall, we really do agree with the general plan here. Just would say that this is not likely to be someone who is well served by surgery, though it would be very reasonable to get pathologic confirmation of the nodal status. But presuming this is N3 disease, that chemoradiation is very appropriate. Carbopemetrexed is a perfectly reasonable backbone, but with some data that indicate that there can be higher rates of pneumonitis with that in a concurrent approach. That said, I also use carbopemetrexed. It's not necessarily prohibitive, it's just a factor that would be considered.